what I'm going to do, again, I think Dan mentioned this, but I have short presentations on lots of different symptom clusters of behaviors within autism and IDD, and you will find a lot of this, thank you, a lot of the review is specific to autism because that's where most of the research has been done, as opposed to general intellectual disability or other genetic syndromes. But I think most of us know there are no medication treatments specifically indicated to treat core symptoms of autism. So what we're talking about here are clusters of behavioral symptoms that are commonly encountered in kids on the spectrum or with ID. So not specifically social communication impairment, and we'll talk a little bit about repetitive behavior. So the first area that I'm going to talk about, first my disclosures. I don't have any conflicts of interest to report. I do have some sources of research support here. All right. So I just wanted, I know Dan brought this up, but I wanted to give an overview of how I was choosing to organize my presentations this year. So if you were here in 2017, we talked a lot about the individual studies and really kind of doing a comprehensive review of the literature. Those all were used to inform the guidelines, and what I'd like to focus on this year is updating you on anything that's new as of the last 2 years. So anything published from 2017 on, we'll spend a little bit more time updating our knowledge in that area. And then what I've tried to do is take any new information and synthesize it with that old data that we discussed last time. And I chose this framework to use this year as a way of trying to organize our thinking about the strength of the evidence and how strongly we want to recommend or not recommend certain treatments. And this is from the Oxford Center for Evidence-Based Medicine. So they have 5 levels of evidence. One is the highest strength of evidence, going all the way down to 5. So you'll see a level 1 is that there have been multiple randomized controlled trials, and that those have been synthesized in a systematic review or meta-analysis, and that those studies have some homogeneity either in their outcomes or their samples. A level 2 would be an individual randomized controlled trial that strongly supports evidence, or an observational study where they've seen a dramatic effect. 3 would be more like case series or cohort studies. Actually 4 is a case series. And then 5 is just an expert opinion consensus or information from perhaps animal models or theory-based, mechanism-based reasoning without any studies done in humans. Okay? And then what this group has done is use the levels of evidence to recommend levels for recommending certain treatments or for assessing harms with treatments. So this could be both evidence for benefits and evidence for harm. So a recommendation of A means that there have been consistent level 1 studies. Again, that means multiple RCTs that have been synthesized in some way into a systematic review. A B would be consistent support from individual RCTs, or, and you'll see us do this a fair bit here, extrapolating from other level 1 studies. So that might mean that there's strong evidence for anxiety in neurotypical pediatric populations with certain medicines, and there's none in autism. So what we might have to do is extrapolate with the caveat that there might be important differences in treatment response. Level C would mean that most of our information is coming from case series or case reports, and a level D would mean that the data is either really mixed or that we can't draw any firm conclusions from the available evidence. And for our purposes, what I've tried to do is use these grades to help inform our level 0, 1, 2, and 3 recommendations. Okay. So I'm going to move on and talk a little bit about ADHD symptoms in autism and ID. I think we probably all recognize that this is extremely common, and we could probably take an entire session just debating whether ADHD is a separate disorder co-occurring with these problems or whether they are part of the neurodevelopmental disorder. There's a lot of differing opinions on that, but I'm kind of approaching this as just a category of symptoms that we see. And we see ADHD, kids with on the spectrum meeting ADHD criteria about 50% of the time. It's even higher in certain genetic syndromes like Fragile X and Williams syndrome, where it is really a part of the phenotype. 22q11 about 1/3, and then in neurofibromatosis about half. So a very common target of treatment. And focusing a little bit on autism, it's not surprising that we see a lot of ADHD symptoms within samples of kids with autism, but we also see features of autism spectrum in kids who predominantly have ADHD. So there is this area of overlap where we're seeing shared features like social challenges, sensory processing differences. Both disorders, we see prominent executive functioning, so problems with planning, organizing. We see trouble regulating emotions, so we see a lot of emotional reactivity. We can see these soft neurologic signs, so gross and fine motor difficulty and sleep disturbance. So sometimes in severe cases of ADHD, it's hard to differentiate from autism spectrum, so a fair bit of overlap there. Okay, so the question is often when are we diagnosing ADHD in addition to a neurodevelopmental disorder? And my bias would be that if the level of ADHD symptomatology is above and beyond what we might expect for that child's developmental level, and those symptoms are causing impairment or distress in their own right, that might be a case for treatment and that might be a case for diagnosis. And an example would be thinking a lot about developmental age as opposed to chronological age. So I've seen cases of, let's say, 8, 9-year-olds who have a mental age of 18 months. We wouldn't expect that 9-year-old to sit at a table and do tabletop activities for 20 minutes. We might expect them to attend for 3 or 4 minutes, something more in line with what an 18-month-old might do. And so we need to always take into account whether the expectations for what that child is capable of are realistic. And when we're considering treatment, we usually, again, we have this risk-benefit ratio that we're always juggling. So, something that might push us toward treatment are that these symptoms are causing safety risks. So kids who are impulsively bolting out of the house or the school, who might be climbing up on high things and have had multiple visits in the emergency room, who are impulsively aggressive and hurting family members or other kids. We need to consider whether these symptoms are impacting their ability to make progress at school or to make progress in their other therapies like speech or OT. So are they not progressing with their developmental therapies because their attention span is getting in the way? We have to think about what impact the symptoms are also having on their ability to connect with their peers. And I'm always thinking, again, as the family, as my unit of treatment, and how are these symptoms affecting the family's quality of life? All right. Rating scales can be very helpful, and I think especially because when we diagnose ADHD, we need to see symptoms in 2 different contexts. So we usually get a pretty good parent report from our meetings, but we also want teacher report to see how things are happening at school. And there's a number of different scales available. My personal favorite is the Vanderbilt. I use this most often because it's short. It really follows the DSM checklist. It's got screener questions for ODD, conduct, anxiety. You get a quick read on academic problems. It's 2 pages. I can put my fax number at the top and get teachers to fax it directly back to me, and I've had pretty good success with that. And it allows you to get a symptom count for ADHD. The Conners is another good screening measure. It's not publicly available, but available for purchase. Also screens for ODD symptoms. The BASC you might see used more of as part of a psychological evaluation or testing report. And in really complex cases, I find neuropsych testing can be very helpful. So they can do things like measures of working memory and processing speed, executive functioning. But also, I think even more important is helping to tease out whether there are cognitive or learning disorders that might be masquerading as inattention. So a kid who has a dyslexia may look very inattentive in certain subject areas, may actually avoid reading and writing tasks and look off task and inattentive when in fact they're overwhelmed because they don't understand what they're being asked to do. All right, so this is what we recommended a couple years ago. With all of these symptom clusters, you'll see level 0 is a comprehensive assessment. Level 1, we'll dig into this a little bit more. We recommended methylphenidate monotherapy or guanfacine. Level 2 was atomoxetine or Strattera or methylphenidate augmented with guanfacine. And then our level 3 was to consult with a specialist. One thing we specifically recommended was not to combine two different alpha agonists like guanfacine and clonidine because of cumulative effects on blood pressure and heart rate and sedation. All right, so thinking about assessment level 0, so one of the first things that we should do is define what we're trying to treat. So we know there are different subtypes of ADHD. There's inattentive, there is the combined type, and what primarily are we looking to improve? Is it predominantly inattention, hyperactivity, impulsivity, or both? And for me, this can affect what choice of medication I might choose as a starting point. We talked about assessing safety, and we might even need to take additional steps to reduce risk related to impulsivity and low safety awareness. And that could be, for this population, things like GPS trackers that kids can wear, or alarms on doors, or deadbolts that are high up on the door, or just counseling about the need for extra supervision. Other little things I've done are things like handicap placards for families who need to be able to park close to a building so they're not having to span a parking lot with their child who has trouble regulating their activity level. We need to get parent and teacher report using rating scales. Always, as with anything, we're reviewing educational reports. IEPs often have a nice summary of how things have been going in the classroom. Neuropsych reports, any other developmental therapy reports. Ruling out learning disorders or language impairment as the primary problem. Thinking about whether the academic instruction that a child's getting is a good match for their cognitive ability. So a kid who's being asked to do more than they're capable of may be, again, avoiding or looking inattentive because they're not being challenged at the appropriate level. And for kids with autism, I think a lot about sensory needs too. So we know a lot of these kids have a high need for physical activity, a high need for movement, for sensory input. And sometimes those things can be calming as well. So having movement breaks, access to fidgets that aren't too distracting, use of specialized seating or standing desks can be very helpful. And then thinking about whether there could be any medical explanations for the symptoms that we're seeing. So we know kids who are severely sleep deprived will look inattentive and hyperactive. Absent seizures, we know seizures are more common in these kids, so could they be missing information because they're having these seizures? Are there any medication side effects that might be causing someone to look inattentive? So we know atypical antipsychotics can cause some cognitive dulling, they can cause sedation. Is that an explanation? Same thing with some of the anticonvulsants. And then, as with everything, we're screening for psychiatric comorbidity, things like anxiety. So kids who are very anxious may be so internally preoccupied that they're missing information. Okay, so if we've done all that and we've established that medication is warranted to manage these symptoms, then we have some familiar treatment choices here. We have stimulants and non-stimulants. And then within stimulants, amphetamines or methylphenidate. Within non-stimulants, we have alpha-2 agonists and atomoxetine. So the choices are very much the same as they are for garden variety ADHD. Third line are things like bupropion, atypicals for very severe hyperactivity, impulsivity, and amantadine, but there's not a good deal of evidence to back those up. So here is what has come out since we last met in 2017. In the stimulant category, there is one new systematic review from the Cochrane database on using methylphenidate in autism specifically. There is an open label study of differing doses of Quilivant, which is long-acting liquid methylphenidate. For atomoxetine, there's been one very busy group that published 3 secondary data analyses coming from one randomized controlled trial that we talked about last time, where they were looking specifically at parenting, stress, sleep, and adverse events, and we'll talk about that. And then in the category of guanfacine, alpha-2 agonists, there is a secondary outcomes paper from an RCT looking at secondary measures of oppositional behavior, anxiety, repetitive behavior, and sleep. So I'll talk a minute about this systematic review that came out for methylphenidate. They were looking at 4 published RCTs. All of them had a crossover design where for part of the time kids were getting methylphenidate at differing doses, for part of the time placebo. These were all short-term studies, so they were assessing effects over 4 to 6 weeks. The combined N is 113, which is not huge for 4 studies, but you can see the biggest one is that RUP trial, Research Units on Pediatric Psychopharmacology, ASD network. We spent a long time talking about that particular study last time. And you see that there's a range here of outcome measures, but most of them have included the ABC hyperactivity subscale, if not as a primary, then as a secondary. 3 out of the 4 were using short-acting methylphenidate, and this systematic review included one that looked at extended-release methylphenidate combined with an afternoon dose of short-acting. So this is how they have standardized their results. They use 2 standard reporting measures or measures of effect. One is a standard mean difference and one is the mean difference. And which one they use depends on whether they had enough of the same scale to look just at differences in raw scores combined across the studies. When there was a lot of variability in the outcome measures, they converted it to a standardized mean difference, or an SMD. And in this case, a negative SMD means that there was symptom improvement, so scores were going down, they were less symptomatic. And the way that we judge them is similar to the way we judge effect size. So something below 0.5 is considered to be a small overall effect. Something in the range of 0.5 to 0.8 is a moderate effect. Anything above 0.8 is considered a large effect. And for this review, they set their threshold for clinically relevant improvement as 0.52, so in that moderate range. And they reported for this review there was a number of limitations in their ability to draw firm conclusions. And some of these could be fixed with other study designs and some probably not. So one is that all of them assessed only short-term improvement, so 4 to 6 weeks again. There are a lack of validated outcome measures specific for autism. That is a problem across the board with autism research and not just these ADHD studies, but there aren't great measures that were designed specifically for use in kids with autism. And there was risk of bias due to recognizable side effects. I think some of that is unavoidable because families could guess what treatment arm they were in based on things like sleep and appetite, and so there's only so much you can do to blind those effects. Also, some of these studies excluded kids in a lead-in phase who couldn't tolerate a minimal dose of methylphenidate. So there might even be some underestimation of some of the adverse events that we see in these studies. So overall, their conclusion was that the magnitude of effect was difficult to determine because of the low quality evidence. So they weren't wholeheartedly endorsing their findings. But what they did find was that higher doses of methylphenidate This would be in the range of about 0.5 milligram per kilogram per dose. So that might translate into something like 1 to 1.5 milligrams per kilogram per day. That was significantly helpful for hyperactivity. And they found that in ratings both from parents, using the ABC as their guideline, and then from teachers. So they found a standard mean difference there of 0.78, so a moderate approaching high effect. They saw some statistical significant improvement in teacher ratings of inattention, but it was statistically significant but didn't meet their bar for clinically meaningful. And then they didn't have enough data specifically on impulsivity to make a recommendation. They did not find any evidence across these 4 studies that methylphenidate worsened or improved the core symptoms of autism on those measures, and that was not statistically significant. There were no serious adverse events, which doesn't mean no adverse events, it just means none that sort of met that bar of being serious. They did see a difference in lowered appetite, so kids on methylphenidate were over 8 times more likely to report lowered appetite.
So it was per dose, not per day?
So yes, so they did it by per dose, and most of the dosing in those studies was BID, sometimes TID.
So it will be double?
Yes, that's right. So yeah, so thinking like their high dose is 1 to 1.5 milligrams per kilogram per day. I wanted to just review a 2013 meta-analysis because this again combined 3 of those 4 studies with 1 older trial. And I just wanted to point out that their effect size, which is kind of the equivalent here of that standard mean difference, is very similar. They found an effect size of 0.67, which is a moderate effect for treating these ADHD symptoms. And they were also comparing outcomes in kids with autism to outcomes from studies of kids with just ADHD, and found that the rates of side effects like lowered appetite and insomnia were about the same. So about 15% of those samples are going to have some problems with that. But in the autism samples, they were finding higher rates of behavioral side effects. That could be irritability, depressed mood, or social withdrawal. Moving on to this pilot study of the long-acting liquid methylphenidate, I included this because there's kind of a paucity of literature around extended release medications, but I know in clinical practice a lot of us use those formulations particularly for school-aged and older kids because they're easier to administer, they're less burdensome for the families and the schools. So it's important to think about different types of formulations and how they might be the same or different. This was an open label study, so there was no blinding and there was no placebo group. They had initially 3 different dosing arms. So they had one that they considered a very low dose, where the maximum was 10 milligrams per day. Low dose, which was up to 20 milligrams, and what they consider moderate was up to 40 milligrams. So this was not weight-based dosing. What they found in this particular sample of 27 was that nobody was tolerating doses above 20 because of side effects. So they regrouped. They had a moderate, which was their low and moderate group, and then very low, they redefined as their low dose group. So they ended up analyzing 2 different dosing arms. They used the ADHD rating scale as their primary outcome, and then had some pretty standard secondary outcomes, CGI, which is a global improvement measure, the ABC, which measures different subscales of behavior challenges in people who have developmental disabilities, and then a sleep questionnaire. And what they found was that both groups improved in terms of ADHD symptom control. They found a little bit more improvement in their moderate dosing group, so a little bit of a greater effect in that group. And they only saw improvements in some of these other behavioral symptom domains in the group that was taking the higher dose. So they did find some improvement in scales of irritability, social withdrawal, stereotypy, hyperactivity, and inappropriate speech. And they also saw greater global improvement in that moderately dosed group. They didn't report any significant side effects. Again, the dosing here was a little bit lower than what we've seen in some of those other studies, which might have some bearing on that. Of course, this is an open label study, so it has some important limitations that we just want to keep in mind. One is there was 27 children, so a very small sample. There was no placebo comparison. There was no blinding of the dosing. And importantly, these kids were allowed to continue other medicines that they were already taking, which included things like guanfacine and clonidine. And there's no teacher report. So, it's pretty common in open label studies to see improvement across the board, and so we can't really discard that expectation bias that we see in open label studies. Any questions on that or thoughts before we talk a little bit more about guanfacine?
Was there anything about how long, the duration of the effects?
So all of these are short term, yeah, so they were really limited to that 4 to 6 week treatment period.
But like at the end of the day?
In the day.
Yes,
Across
during
the
the
day.
day, right, across the day.
Oh,
Because they didn't get teacher reports, but
right.
then were the parents reporting that
Right.
they were fine when they came back after school and they sat and did their homework?
Yeah, I know in that largest study that there was flexible dosing between 2 times a day or 3 times a day.
Okay.
So
was
I
my
think
next
they were
question.
aiming for 3 times a day, but some of the kids were having sleep difficulty and they were allowed to back off to twice a day in that case.
So the Quilivant was administered up to 3 times a day?
Oh, no, the Quilivant was once daily.
Okay.
Once daily. There was just the one study from the meta-analysis that looked at extended release. I think it was, I can't remember, it may have been Concerta in combination with the short-acting in the afternoon. But all the other ones were using just short-acting methylphenidate dosed 2 to 3 times a day. Most of the data was related to stimulants. I'm going to move a little quicker because all of this is really secondary data. This one I'll just spend a minute on because I wrote this paper, so it's close to my heart. This was a study of Intuniv, guanfacine ER. We talked some about the primary outcomes last time, which were ABC hyperactivity reports. There's about a 50% response rate specifically for hyperactivity. There's an N of 62, so all children and young adolescents. And we took a look at some secondary outcomes through some measures of oppositional behavior, anxiety, repetitive behavior, and sleep. And in a nutshell, what we found was that there was some improvement that was statistically significant in oppositional behavior and repetitive behaviors. So not unexpected, given that the overall hyperactivity was decreased and impulsivity. We didn't see any differences in anxiety, which I think is noteworthy because sometimes these medications are used off-label for anxiety. However, baseline rates in this sample of anxiety were quite low, so we weren't really powered to detect a difference there. And then with sleep, we didn't see any significant differences. All right. Strattera, there has been one new systematic review and meta-analysis. There are 3 primary RCTs that have been done. The largest was this one by Handon in 2015, where they did this parallel group 4-arm study where they had one group just atomoxetine, one placebo, one atomoxetine plus parent training, and one just parent training. So this study did find effects in the moderate range, again, for both inattention and hyperactivity. So very similar to the kind of combined effects that we see with methylphenidate. There were a fair number of minor adverse events that are very similar to what we see in kids who have ADHD without autism. Again, their conclusion was that the overall evidence was fairly low quality for drawing firm conclusions, but that it looks to be at least moderately helpful for hyperactivity and inattention. There were 3 secondary outcome reports for parent stress. Here they did not see any group differences in levels of stress over the 10 weeks of the study. For sleep, they did also not see any significant changes. And for adverse events, they found the most common things were lowered appetite and fatigue, and that there were no significant safety concerns. One thing I thought was noteworthy was that adding parent training to atomoxetine improved rates of mood dysregulation. So that even though that combined group didn't separate from atomoxetine alone in the primary study for ADHD outcomes, it looks like adding that parent training component can be helpful for some of the mood reactivity that we see around these kids. So here's and again, this is just my assessment of the evidence, and this does not come from any published reports. I still think that methylphenidate is kind of our first line with the most evidence behind it. Guanfacine and guanfacine ER, we've got data from 2 fairly sizable RCTs. There haven't been any systematic reviews. And just clinically, I think there's good evidence for hyperactivity, but no compelling evidence that it's very helpful for inattention. So it might be level 1 for hyperactivity, but level 2 for the combined type. Clonidine, there have been 2 very small RCTs with less than 10 participants each. Not even all of those studies were focused specifically on ADHD symptoms. I wouldn't recommend adding it into our algorithm here. And then finally, atomoxetine. We now have a systematic review of 3 RCTs in autism. It looks to be the effect sizes are comparable to methylphenidate, but maybe not quite reaching the same level of evidence. So this is just a summary before we move on to talking about the recommendations. The 3 main things, methylphenidate, guanfacine, atomoxetine, have similar response rates in the 50% range. Similar effect sizes. It doesn't seem like it matters too much whether you're using short-acting or long-acting, that they might be equally efficacious. Guanfacine may be a good alternative to a stimulant when there's poor tolerability and that target symptom is hyperactivity. However, methylphenidate and atomoxetine have more compelling data for inattention. And as we were talking about, their choice may be guided by other factors too, like their ability to swallow pills, or how old they are, or what you're trying to target specifically. So what we see basically is that in kids with autism and ID, response rates to things like methylphenidate are lower than we see in ADHD, and there's a higher risk of behavioral side effects. So that's always a factor in our risk benefits decisions too. Okay.